in his room crying. Ryan's like, all right, I know it's obviously wrong, but what? Tell me. And I'm like, we're so irresponsible. I'm like, we are the most irresponsible people that I know. I'm like, how are we gonna do this? Like, I couldn't see us do, like, we had already had a child. We had his sister, and we raised her through trial and error.
Mm-hmm.
You know what I mean? Like,
I'd like to say thank you. I hope you guys enjoyed lunch. Tess, I'm trying so it don't sing to Dr. Thornton while he's talking like it was earlier. Okay, we do have test 1, 2. They are going to bring a fan in here because there's one AC that is out, and so they're going to bring a fan and set in the back for you guys, and I apologize. We do want to answer the questions that some of the ladies had on live stream, and I would like to have Dr. Thornton come back up here so we can address some of the questions that some of you ladies had to ask over the internet. And thank you. Just start singing to you, just kind of thing.
Thank you, Angela.
thank you, sir.
I'm getting old, so I have to put my old man glasses on. So, a lot of people emailed in and asked questions who couldn't be here today. So I'm going to go through a selection of those questions and just answer them. And then if you guys have anything else, we'll talk about that. So the first question that comes in is, how long can a patient stay on diazoxide and chlorothiazide? And so the answer to that question is as long as you need to. So diazoxide, as you know, is a drug that acts on the KATP channel and impairs insulin secretion. And so the idea is that in children with hyperinsulinism, you slow down the amount of insulin secretion and you keep the blood sugars in the normal range. And interestingly enough, when we look at the kids who are responsive to diazoxide, there's one group of children who respond very well to diazoxide, and they're the babies with transient hyperinsulinism. And you'll never find any mothers of babies with transient hyperinsulinism at these meetings, because these are babies in whom they have very low blood sugars in the newborn period. We put them on diazoxide. They get completely fixed with the diazoxide, and after about 3 to 4 months, or maybe 6 months, the hyperinsulinism goes away. You take them off the diazoxide and they're cured. And why that happens, we do not yet know. We've looked at different genes to see what might cause this, but at the moment we don't know the cause of it. And then you have what we call the genetic forms of hyperinsulinism, which you have forever. And in that case, if you're responsive to diazoxide, then usually you need to be on diazoxide for a very long time. Now, have we ever seen some older people who've come off diazoxide? Absolutely yes. I've looked after people as old as 60 who some of them were born before diazoxide was available, and so they were never on it, but they managed their disease with diet, and these tend to be the autosomal dominant children or adults. They tend to be much milder. But I've also seen kids who, at the age of 7, 8, 9, 10, or when they become teenagers, have been able to wean off the diazoxide, and if they go for a long time without eating, they'll have low blood sugars, but nonetheless they can get to the point where they're able to go overnight without eating and their blood sugars are stable. So many children do wean off it eventually, and some people need to be on it forever. Chlorothiazide is also known as Diarrhea, and that is a diuretic, meaning it's a drug that helps get water out of your body. And as you know, diazoxide sometimes makes your body hold on to water. So we add in Diarrhea or chlorothiazide, and that helps get rid of that water. And so some people are on both diazoxide and chlorothiazide or Diarrhea. And so you can be on them as long as you need to be. You've got to remember that you have to weigh up the risk of low blood sugar versus the risk of the side effects of the drug. And if the risk of the side effects of the drug are less than the risk of low blood sugar, then you really stay on it. So the bottom line is that anyone can stay on the drugs for as long as is needed. And in fact, if you look at the FDA indication for diazoxide, the dose in adults is 2 to 3 milligrams per kilo per day, whereas in children it's 8 to 15 milligrams per kilo per day. This sort of reflects the fact that adults need less drug per kilogram of body weight. And so actually, as kids get older, it is a natural tendency for that dose to perhaps drop a little. And those of you who are on diazoxide may see that compared to the newborn period, that you're already on, even though the amount of drug is more, it's less per kilogram. Okay, does anyone here have a question about diazoxide or Diarol? We'll add that in. No? Yeah?
I do. I'm sorry. Why does that particular medicine cause babies to have a lot of hair?
So the question is, for those who couldn't hear, is why does diazoxide cause excessive hair growth? So the answer is we don't quite know the mechanism, but it's presumably very similar to some of those other drugs like minoxidil. And so it stimulates the hair follicles to grow faster. Actually, my friend and mentor Lester Baker, who sadly died in about, I think it was 1999 or 2000, he's the one who trained Charlie Stanley, who trained me. But I had the good fortune of working with him for about 10 years. And he would have been a rich man, except for one fatal mistake. And let me tell you what that was. He was one of the first doctors to use diazoxide. And when he used it, he saw that all his patients started to get hairy. So he had a dermatology friend, Paul Honig, who was completely bald on his head. And so he said to Paul, "Hey Paul, let's make this into a paste and rub it on your head, and if your hair grows, we'll make a fortune." So they made it into a paste and rubbed it on his head, and nothing happened. So they gave up on it. And then about 15 to 20 years later, this drug was developed for rejection for people who had kidney transplants. It was called minoxidil. And when they gave the people minoxidil, they found that it made their hair grow. And so another doctor thought to himself, boy, if I rubbed this on a body and it made the hair grow, I could make a fortune. So he got a friend and rubbed it on his hairy arm, and the hairy arm grew more hair. And they made a fortune and they became wealthy, because that's what we now call Rogaine. So it probably works just as good as Rogaine does. The problem is that Dr. Baker tried it on someone who had no hair follicles left, and Rogaine was tried on people who already had hair growing, and so it made that hair grow thicker and stronger. And so when Lester Baker was dying, he had lung cancer and he was very, very sick, and I remember saying to him, "What's your biggest regret?" And he said, "It's that I rubbed the diazoxide on Paul Honig's head instead of his arm." So that was a funny little story about diazoxide. But the bottom line is it stimulates hair growth, but we don't exactly know how. Okay, so the next question is, when was the first case of hyperinsulinism recorded in Europe or America, and what was the outcome? The answer is I don't really know, but cases were published as far back as the 1950s, and Macquarie knew about this, and in fact there's some very interesting families around who were described as having autosomal dominant hyperinsulinism back in the 50s and 60s, and they now are a few generations on, and we actually met that family, and we met the grandma who was the baby that first got described. So there are people who've lived to a ripe old age with hyperinsulinism, but in the old days, of course, because the risk of damage was so high, and 50% of the kids who had hyperinsulinism had serious neurological damage, they had a shorter lifespan. But if for the kids who were okay, they've lived many, many years. So if the question is, how old is the oldest person? We've certainly seen people, I believe, up into their 70s, but I'm not sure when exactly the very first patient was ever described. Another question we got asked was, after a child has 99% of their pancreas removed, how often have you seen the pancreas grow back, and if so, how fast does it grow? So this is a very interesting question, because the general sense of physiology of the pancreas is that the pancreas does not regenerate itself and does not grow back. So there are certain things if you damage will grow back and heal, and other things if you damage will not grow back. And the pancreas was always thought to be in that category that does not grow back. It turns out that there is still growth of the pancreas over the first few years. So, for example, if you leave in a nubbin of tissue that's, say, 1/4 of a centimeter by 1/4 of a centimeter, about that size, and you come back and you look, 3 years later, will it be bigger? Well, yes, it will be bigger because it will grow with the child. But I did some studies with some of my colleagues in Israel, and what we did is we looked at focal and diffuse tissue that had been operated on, and we stained it looking for markers of things that cause cells to die and for things that cause cells to reproduce. And what we found is that the focal lesions had a combination of both markers. So they had things that caused the cells to die and things that caused the cells to continue growing. And so it is possible that the focal lesions might proliferate a little bit more. But as a general rule, I think it is fair to say that if 98 or 99% of your pancreas is taken out, in the vast majority of people, it will not regrow. The little bit will get a little bit bigger, but it's not going to regrow back to 50% of your pancreas. Okay. Does anyone have any questions on that one? All right. So I got a question, is that how many children have both hyperinsulinism and low pituitary hormones? Because this lady Carolyn says there seems to be a couple that I found, and she wanted to know how common is this. Now, that is very interesting for two reasons. Number one is because the most common thing to be confused with hyperinsulinism in the newborn period is a condition called hypopituitarism. And so sometimes an incorrect diagnosis can be made. So for example, I saw in Fort Worth a 3-year-old girl who was diagnosed as having hypopituitarism because she had persistent low blood sugars in the newborn period, and she had slightly low growth hormone and cortisol levels, and so she was treated as having hypopituitarism. And when she came to see me at 4 years of age and she told me the story, I thought there was something wrong about the story, and I looked at her very carefully. We brought her in, we did a fasting study, and we found that indeed she had hyperinsulinism. And so we took her off the growth hormone and cortisol very slowly, and found after we took her off that that had recovered. So the first point is that sometimes the wrong diagnosis can be made because they're sometimes may be difficult to separate out. However, having said that, there have been some cases reported by Khalid Hussein in London that show that some children with hyperinsulinism, when you look at how their bodies respond to stress, did not make as much cortisol as maybe they should. And so is there an association between hyperinsulinism and cortisol deficiency from hypopituitarism? And so there seems to be some people who have that. The other thing that we've seen is we've now seen 3 or 4 children who have both hyperinsulinism and growth hormone deficiency. And so it turns out that the chances of having hypopituitarism is 1 in 50,000, and the chances of having hyperinsulinism is 1 in 50,000. So the chances of having both is 1 in 50,000 times 1 in 50,000. So that's very, very rare, but every so often it might happen. So as a general rule, we always ensure when we have people with hyperinsulinism that they do make enough growth hormone and cortisol, and that's part of the workup. So some of you will remember when your babies were born that a load of blood was drawn at the time of the low blood sugar, and 2 of the hormones that we measured during that time is cortisol and growth hormone. And then if those levels are low, but we believe the patient has hyperinsulinism, we'll sometimes go and do further testing to show that their cortisol and growth hormone levels are okay. And so the bottom line is there is a slightly increased risk of an association of low cortisol and growth hormones, but one has to be very careful to make sure that that is the correct diagnosis.